My name is Mark Booten. I'm the CEO of the National Health Council. Welcome to this afternoon's webinar. The National Health Council is an organization created by and for patient advocacy organizations. We're nearly 100 years old and include many of the nation's leading patient advocate organizations. We are unique in that we have all stakeholders represented in membership, and that includes the biopharmaceutical, device diagnostic, generic, payer, researcher, family caregiving communities. Today, our objective is to introduce the National Health Council's rubric to capture the patient voice, the healthcare community. We're looking forward to hearing your thoughts on the rubric and having a discussion and answering your questions about it. A number of speakers here today. You'll be hearing from Elizabeth Olerin, who is our Senior Director of Research and Programs here at the National Health Council. You'll also be hearing from some of the folks that helped us to develop this tool, Matthew Pickering, Patrick Wildman, and Elmer. So we're looking forward to hearing from all of you. Take a moment to thank our roundtable participants who helped us to put this rubric together. And you see a list of those folks here, incredibly helpful, and also a group of people representing diverse stakeholders. Wanted to point out that the rubric to capture the patient voice is really meant to be an umbrella tool. It's our hope that we'll see rubrics in specific areas of health developed over time. In fact, the PFMD, Patient-Focused Medicine Development Group, which I am a part of, actually created a quality guidance that details how to engage patients throughout the life cycle of drug development. The National Health Council had previously developed a rubric for value assessment, and we are finalizing, or I shouldn't say we, the Pharmacy Quality Alliance is finalizing a patient engagement and quality measurement rubric. So it's our hope is that this will serve as a tool, and we'll see a proliferation of more specialized tools underneath it. With that, I will turn it over to Elizabeth.
Thank you, Mark. Before I get started, I wanted to let everyone know that if you have a question during the webinar that you'd like to ask, please submit it through the WebEx chat function, and we'll be taking all questions at the very end of the presentation. I will now be introducing the purpose of the rubric, describe its intended uses, the development process, and finally the structure before I turn it over to our guest speakers to introduce the individual sections. So first, let's review the purpose of the rubric. The purpose is to provide a tool the patient or any other stakeholder can use to evaluate attributes of patient-centeredness and to guide them on meaningful patient engagement throughout any activity they might undertake. It can help answer questions such as, was an activity patient-centered? Were patients meaningfully involved? And it's broadly applicable and more general in scope as compared to prior patient engagement rubrics, as Mark mentioned. We see the rubric as a general blueprint for any setting where patient centricity is desired. For example, patient centricity in research, patient centricity in drug development or device development, and others, including policy development. You might be wondering, why did we develop the rubric? It's because we still see and hear confusion about misuse of what it means to be patient-centered. We wanted to help the stakeholder community understand how to achieve meaningful patient engagement. This is a generic tool, and we see it as complementary to other tools that are out there that capture nuances of patient centricity in specific settings. Patient centricity is more established in certain fields than others, and we believe that this rubric can be particularly helpful in areas where guiding practices do not yet exist and complementary in those where they do already exist. This slide describes the development process that we use to develop this rubric. As can see, it was an iterative process. We started in February of this year with a multi-stakeholder roundtable discussion, and we acknowledged the individuals who participated in that meeting. We then drafted the first rubric based on the roundtable discussions and circulated it back to roundtable participants and revised the draft based on their feedback. We then opened up the draft to a public comment period on draft 2. Again, we revised it based on the input that we received. And then we submitted this next draft back to the roundtable participants, and the rubric was finalized in its current state. So I wanted to really thank everybody who participated in this process, including those who helped us by submitting comments. If you haven't yet had a chance to look at the rubric, here is a snapshot of what you will see in the table of contents. We describe a section where we describe uses and intended audiences of the rubric. We introduce definitions. We describe domains of patient-centeredness, which Matt will be reviewing. Then we describe different sections of the rubric. The first is about meaningful patient engagement processes, and the second is general patient-centeredness considerations. And so as you'll see in the subsequent sections, we go through the domains of patient-centeredness in the context of what it means in meaningful patient engagement processes, and also the domains of patient-centeredness in the context of more general considerations that don't relate directly to patient engagement. We then have provided a number of real-world vignettes. These include vignettes from drug development, medical device development, policy development, and also health delivery. I wanted to just highlight some of the definitions and front matter that you'll be seeing in the rubric. These include definitions of what is the patient community. For example, definitions of patients, family caregivers, patient organizations, as well as a more recently developed definition of online patient communities. We also walk through and provide examples of what does patient-centered mean, what are the characteristics of meaningful patient engagement, and then also what are insights that are derived through patient engagement. For example, we describe patient-provided information, what it includes, what it doesn't include, and additionally, we have a glossary as an appendix. To now turn it over to Dr. Matthew Pickens to describe patient-centricity and introduce the domains of patient-centeredness.
Great, thank you, Elizabeth. And it is a pleasure to be involved in this great effort and this great work. As Mark had mentioned earlier, my organization, the Pharmacy Quality Alliance, is developing a rubric for quality measure development. And a lot of the concepts from this work have been embedded within that rubric itself. And we're very excited to be involved in this, so thank you very much. And when we think about patient centricity, the National Health Council has defined this within the rubric, as you'll see, as any process, program, or decision focused on patients in which patients play an active role as meaningfully engaged participants. And this is with a central focus on optimizing the use of patient-provided information. So the key thing really to think about here is that patient-centered means doing things with patients or patient partners within the room or within these activities, not just for them or to patients. And if you go to the next slide, when we want to think about what this really means, what does it mean to be centered? Well, the National Health Council has several years of work into this space to really describe this and characterize this even further. And you can see 7 domains here. They've seen patient community stakeholders and roundtables, looked at previous rubrics around patient engagement to come up with these 7 sort of domains for this rubric today. One being patient partnership, transparency, representativeness and diversity, the outcomes that patients care about, patient-centered data sources and methods, and timeliness. And depending on the activity or process or thing that is to be accomplished, there may be various different characteristics to consider across all of these domains, and what we'll be giving examples later on in the presentation. So next slide. What I will be talking about is just briefly describing these in a little bit more detail. So the patient partnership here is really that patients should be really involved in every step of the process of whatever it is that you're trying to do. And some of the key characteristics within this domain to consider are things like co-learning, co-development, obviously trust and transparency, which creates this environment of honesty and respect, but also reciprocity. And so, for example, with reciprocity, if you have a vote that needs to happen within a panel or a group in which patients are involved, make sure that vote is equal across all the stakeholders within that. There's equal vote that happens, for example. In addition to the patient partnership, there's considerations to think about as well as tools or training that may need to happen to increase the patient's capacity to engage meaningfully with whatever activity you're doing. But also the flip side of that as well, to ensure that the staff, people or persons are also adequately trained to engage patients in a more meaningful way. So it's something to consider with patient partnership. With transparency, really, it's just all the activities that have been conducted are done in an open way. All assumptions, processes, and results should be disclosed to those patients in plain language in a timely fashion. And so consider the patient group or the patient community that you're engaging, and also consider the health literacy of that population as well. So keeping communications and dissemination efforts across that community with health literacy into consideration. And then there's representativeness, something that we all hear about in probably our own circles when we're trying to engage patients, is making sure that there's a sufficient number and types of people that are included in the engagement activity. So a key thing really to think about is the who and the how many individuals and who they are to include in order to speak on behalf of that target population. And so this is not just doing statistical sampling to ensure you're meeting a certain threshold. It really should be thinking about who and how many and the context of that engagement activity for representativeness. And there's a lot of detail and explanation and examples within the rubric that describe this further. If we go to the next slide, sort of wrap up on the last remaining four, there's just diversity. So the activity should consider differences among patients, including those subpopulations, the trajectory of the disease, as well as the stage of the patient's life. And as we were developing our rubric, there was such a great example that was shared, is you may have patients that you're trying to engage around prostate cancer. So you have men there, but you want to make sure that there's potential subpopulations or different types of men there that offer that level of diversity to whatever it is you're trying to do. Then there's the outcomes that patients really care about. So whether this activity is research or policy or even quality measurement, making sure the outcomes are being measured should include those that are meaningful to patients and maybe even prioritized to patients. There's really a common misconception that all patient-centered outcomes are patient-reported outcomes, or PROs, pros, and that all pros are patient-centered. But neither of these is really true. You can have patients prioritize or weigh in on what is meaningful for them as far as an outcome to be symptoms, right? Fatigue, pain, et cetera. So you can have that happen, but sometimes patients also prioritize outcomes that are not symptoms. They may prioritize other things like biomarkers, et cetera. And also, depending on the patient-reported outcome, this outcome has actually been developed without patient input at all. So you have to really make sure that whatever outcome that you're measuring or trying to achieve actually had meaningful patient input to developing that outcome. And so there's something to really consider when you're doing an activity here. And then patient-centered data sources and methods. So there's a variety of these credible data sources that are out there and can facilitate incorporation of new information and account for the diversity of patient populations, patient-centered outcomes. And excuse me, so patient-centricity can be achieved by employing a range of methods, including both qualitative and quantitative types of approaches. And lastly, it's just timeliness. So engaging patients in a timely fashion, but also keeping in mind where they are and potentially say their disease course or their trajectory or where they are in their certain area within life as well. So timeliness, but also effective and relevant to meet the objective of that activity. And those are the 7 sort of key domains. And now I'll be turning it over to go into section 1, which is meaningful patient engagement. I believe that's Pat.
Yep, thanks. Thanks, Elizabeth, for leading this webinar, and really thanks to NHC for all their work in these areas. It's critically important, especially in these times where patient centricity and patient engagement are playing such an increasing role in all of our organizations do. And the Lupus Foundation has been very pleased to play a role in this. Now, I wanted to, next slide, wanted to go through some characteristics of meaningful patient engagement. And really when we talk about meaningful engagement, what we're referring to is relationships and partnerships that are bidirectional, reciprocal, and continuous. So that we're not just talking at patients, but patients are really involved in the entire process. So they're integrated into the process. We're not just speaking to them or getting information from them. Communications are open and honest and clear. And in meaningful patient engagement, the goals, the participants, the methods, desired impacts, and actual impacts are clearly outlined and transparent. So again, it's not just one-sided, which is typically, if you go back 5–10 years, it's typically been one-sided, where we're looking for the patient to provide us with something, but really not really engaging them in a meaningful way. Next slide. So in this slide, really we're talking about, the purpose, the time frame, the resources of different activities can vary substantially. So this slide shows a bunch of different types of patient engagement activities. And really, when we look at a good patient engagement and meaningful patient engagement in any given activity, we think it should have a combination of these different forms of engagement, whether it's stakeholder-directed, led by patients and patient groups, whether it's a collaboration where patients serve as a member of an advisory committee, or patients are serving as consultants. They're participating in interviews, focus groups, surveys, and even an informal discussion with patients, unstructured discussions where it's a back and forth, and as study participants. So these are just a few examples of different ways for meaningful patient engagement. But the bottom line that should flow throughout, and what's been discussed earlier, is that these, however we're engaging patients, it needs to be more than just one-sided. It can't just be them providing information. They need to be involved in the entire process, and it needs to be bidirectional and continuous. Next slide. And actually, before I talk about this slide, and the next few slides are all examples of meaningful engagement and insufficient engagement, I do want to say that just simply participating, for patients just simply to participate as subjects as part of a research project or as part of a survey isn't sufficient to be meaningful. There's got to be much more to it than just that. So I did want to spend some time over this slide and the next 2 slides to go through some examples of meaningful patient engagement. And the first one here with the domain of patient partnership, the example we provide here is patients are recognized as partners and integrated in all development phases. And an example of meaningful patient engagement here is a patient and family advisory council identified a challenge, co-developed a solution with the hospital staff, implemented the planned solution, and measured the impact. Now, an example of insufficient engagement here is the advisory council identified the challenges, but the hospital and the healthcare providers developed and implemented their solution without input from the council and without involvement of the council. So clearly, on the left-hand side with meaningful, it's really getting the council, the patients, more involved throughout the process, not just at the beginning or not just at the end. And then the next domain with transparency to patients. Our example is the process for selection of patient partners, representatives, is transparent. An example of meaningful engagement here is the specific criteria used to identify, select, and invite patient representatives were disclosed along with the rationale. Whereas the insufficient example is that there was no systematic process for selecting patients, that it was just randomly going and picking select patients to be invited. So it's fairly clear the differences here, and again, without to overstate it, the key difference is just making sure that we're involving patients and patient organizations throughout the continuum. Next slide. Now, with patient partnerships, the example we have, and actually the previous slide. There we go. Patients this is, oh, actually, I'm sorry, I did this one. Apologies. So yeah, and in this slide with the next slide, please, with patient-centered data sources. The example we have is when gathering data, stakeholders consider how to best protect the patient's health privacy. And a meaningful example is data collected from a digital application is anonymous, securely stored, and shared according to the patient's wishes. And an example of insufficient patient engagement is the data was obtained from a digital health application and was used for research, but the patients were not notified until after a report was completed. So you can see the common themes throughout. Next slide. And in this final slide, we talk about outcomes that patients care about. And I think in a lot of what we're doing in patient engagement is like trying to identify, and I think Matt just talked about this, trying to identify what outcomes are important to patients. And we have the example here of, listing all the different types of outcomes. And the example we provide is, researchers partnered with a patient organization to identify a disease-specific outcome measure. After speaking with patients, it was determined that the new measure should be a PRO. Patients were involved throughout the development and validation process. An insufficient example of that would be previously developed PRO was included in a trial. However, the measure was not developed with patient input and did not reflect the outcomes currently most important to that patient population. And on this issue, I wanted to just give an example of something that we went through as part of at the Lupus Foundation is when we were preparing for our externally led PFDD meeting a couple of years back. As part of that effort, we created a survey to get patient input on, what it's like to live with the disease, what outcomes are most important to them, what impacts on their daily living or what things had the biggest impact on their daily living, on their quality of life. And we, as a patient organization, we believe we have a pretty good sense of what those things are. So as we created that survey, it was a pretty comprehensive survey about 65, 70 plus questions, looking at those various different issues. We drafted the survey thinking that we had again, a pretty good handle of it. But what we did, instead of just putting the survey out and asking for feedback, we had a number of patients got input from them about, are we accurately capturing all of this? Are there questions that we're missing? Are there things that you think are important that we don't have included here? And we did identify a number of things that did not occur to us or that we had missed. So it was critically important that we involved patients at the beginning of the process. We put out the survey. We shared with them feedback from the survey. We got further input. So patients were engaged throughout the process. We weren't just doing this to get their feedback. We wanted them to be engaged throughout. And it made, at the end of the day, it made our report to FDA much stronger, and it further informed our continuous work to engage patients and continue our efforts in these issues. So the bottom line, and I think the common theme is again, really to keep patients involved in everything that you're doing, whatever the project may be or whatever the goal may be. But it's critically important in order to get a really meaningful engagement and getting meaningful patient input is to include them throughout the process. And with that, I will turn it over.
Great. Thank you so much, Pat, and also for the real-world example. I'd like to now turn it over to Mary Elmer from Merck.
Thank you, Elizabeth, and thank you to both Elizabeth and Mark, and on behalf of the National Health Council, the work that you're doing for patients, and for this opportunity to collaborate on this important rubric. So I'm going to speak a little bit, continue the theme on Section 2 for general patient-centeredness considerations. These are really approaches that enhance the patient-centeredness throughout an activity, but are not direct patient engagement. Next slide, please. So the first domain is representativeness of patients. And this is something I think we've talked about before. And our example here is opportunities for patients and organizations to participate are broadly disseminated and sufficient time is provided to respond. So here we have two examples of meaningful and insufficient representativeness. So meaningful would be a piece of legislation would have a substantial impact on patients. So it's broadly released, disseminated to the patient community, and a 60-day period is provided to ensure that both small and large organizations could respond appropriately. So an insufficient or low representativeness would be that that same piece of legislation would be, if passed, would still have an impact on patients, but it's released prior to a holiday weekend with only a 10-day comment period. And only patient groups with substantial resources would be able to prepare comments. So again, opportunities for patients to provide their comments are broadly disseminated and sufficient time is provided for them to respond. Next slide, please. So this domain is diversity of patient populations. And here we're speaking about differences in health literacy are considered as reflected by the approach. So we have two examples. A meaningful example of diversity would be a clinical practice guideline development committee with representatives from several patient groups to participate on the committee. The committee specifically asked the patient representatives to provide data on those subpopulations, including by health literacy levels. The communication staff from the organizations were also asked to contribute their expertise, thereby communicating the information to a variety of the subpopulations. So a nice, rich amount of data coming from this meaningful example. An example of insufficient or low diversity would be the same 15-member clinical practice guideline development committee. A healthcare provider who had previously served on the committee for many years, and he was recently diagnosed with the condition, was asked to provide the patient perspective. So here we have sort of a healthcare provider who was a sort of a convenient sample, and this is an example of low diversity for this particular domain. And I'll include one commentary here. This is something that I know in our work in terms of engaging patients, ensuring that we have representative information from patients from subgroup populations and also varying degrees of health literacy is critically important to ensure meaningful diversity when we think about this approach. Next slide, please. The next domain is timeliness. So our consideration here is that engagements happen at the appropriate time throughout the process. And again, we have two examples, a meaningful and an insufficient. So in the meaningful example, we have researchers who are planning to apply for a grant aimed to improve adherence. They reach out to the patient community about 6 months before the proposal is due to provide sufficient time to understand why patients are not adherent and to co-develop a proposed solution. Researchers then invite the members of the patient community to be investigators on the proposal. So now we have an example of insufficient or low. So these researchers independently identify an intervention to improve patient adherence to a medication, and just before the proposal is due, researchers invite a patient to serve as a co-investigator. From that patient community perspective, that proposed intervention doesn't really adequately address barriers to adherence. So in the insufficient or low example, they did not have enough time to really contribute, to be a part of the solution. And as you can see in the meaningful example, they had plenty of time, and then they were even invited to be investigators on the proposal. So I think in these three examples, we're looking at approaches that really influence and have contribute meaningful engagement with patients. So next slide, please.
Great. Thank you so much.
Thank you, Elizabeth. Oh, I was just going to introduce this slide. Now we're going to speak about using the rubric in conjunction with other resources. Thank you, Elizabeth.
Thank you, Mary. And just a reminder that if folks have any questions, please feel free to submit them through the chat function. So with that, I'll turn it back over to Matt, who will discuss how the rubric could be used in conjunction with the tool that his organization is developing on developing quality measures.
Oh, great, Elizabeth, and thank you. Again, just very happy to be involved in this work, as a lot of the efforts and discussions that you've heard here, but also within this group in this roundtable developing this rubric, have also been fed and the inputs have been put into the development of the rubric for quality measurement. And so when you think about quality measurement, there are various different types of areas or domains within quality measurement, as you can see here, from measure concept ideation all the way to measure use and maintenance. And CMS, the Centers for Medicare and Medicaid Services, who has implemented a lot of these quality improvement programs in which measures are embedded, has strongly stressed that person and family engagement should occur throughout each one of these areas, throughout each one of these domains of quality measurement. And if you think about the purpose of quality measurement is to help to not only improve quality and reduce cost, but to inform decision-making by the consumer, the patient, the family member, et cetera. But if that's the purpose, we're not really doing a great job of really incorporating the input from the patient community within quality measurement. There may be evidence-based, but we're not really sure if we're incorporating meaningful patient input into the quality measurement process. So the development of a rubric in this space was something that we were very pleased to partner with the National Health Council and also the National Quality Forum in this effort. And using a lot of the domains that we've talked about, patient partnership and transparency and representativeness, et cetera, into this work. And this will be done towards the end of August. And then we will look to the patient community, the partners that we've convened on our roundtable, as well as measure developers that are involved in this work to implement this rubric and start to evaluate and assess meaningful patient engagement within each one of these types of domains of quality measurement. So the rubric that we've been sharing with you today and the domains and concepts have been matriculating into the work that we've been doing, and input and a lot of information has informed the rubric that we've been developing. So thank you very much, Elizabeth.
Thank you, Matt. I'll now turn it over to Mark to present another example.
The patient-focused medicine development's quality guidance is an example of looking at how you develop a tool for drug development. This is an organization that is a collaboration between patient advocacy organizations and biopharmaceutical companies. Put together a plan to look at a variety of different tools and existing frameworks for patient engagement and drug development. And in doing so, they brought in patients and people from the drug industry, as well as folks from regulators, to start to look at the different frameworks and try and synthesize them. And the end product was a quality guidance that has a number of domains, but has had a great deal of involvement that was multi-stakeholder. And it's really created an excellent tool for patient engagement, a very specific tool that is now actually being practiced by a number of different organizations. I think this is a great opportunity, and again, as I said earlier, we'd really like to see more examples of this in very specialized areas where patient engagement would add to different components of the health ecosystem. So with that.
Great. Thank you, Mark. So we've had a number of questions submitted to the chat function. So I'll just pose the questions out to the group. The first question is, what researchers do if they are already partway through an activity and notice that the centricity could be improved? For example, what do I do if I'm on the low end of meaningful, but I'm already halfway through the activity?
So this is Mark. I would say it's never too late to start, and one of our great challenges is that so much research is going on. But if you look at your process and where you are on the continuum, you can start to look at applying some of these principles moving forward to the next set of steps. Certainly our goal that patient engagement would be thought of as part of the planning process in the very early stages and would be systematically thought through and planned so it would be consistent throughout the development. But at the very least, no matter where you are, starting now is always going to improve the output of the product.
I would add that, this is Eleanor Persetta, I would add that, you know, it's always difficult to stop midstream and retrofit things, but if you consider opportunities to begin some engagement in parallel with what's already ongoing, there's a very good chance that you're not going to have to throw away a lot of what you've done. You just might need to retrofit some of it a little bit. So if you do begin a parallel process where you do begin some engagement alongside the work that's already ongoing, you can then take what you've learned from that engagement activity and see how it might be applied, implemented, to improve what you're working on without derailing it too much.
Great, thank you. One other question was, from the patient community perspective, what is the best way to approach your community's researchers, expert panels, or other sort of expert folks with the current patient-centered ideology? So, for example, if you were to take the rubric, how do you actually get them to change or get them to adopt the types of processes or domains that are described in the rubric?
So again, this is Eleanor. I would say that one of the first things to do is always look out for people who you think are champions, so people who you think would be amenable to doing these kinds of things. Because having some of those champions in you early on, the early adopters, can help you to reach the others. It gives you examples of success that helps you reach others in the group. We've found, you know, especially in dealing with some of the clinicians who have been putting together clinical projects for a long time, they know what they're doing, they do them all the same over and over again, that it's just taken an example from one of their colleagues to do something differently and to do some work with patient engagement, to be that spokesperson to say, wow, this changed my thinking, it changed my research question, it changed my approach, and one of their colleagues say it to them, and that can really be effective.
This is Mark. I would encourage people to look at a model called the Innovation Adoption Curve. And in that, it talks about how new ideas hold. Because at the fundamental challenge you have is you're really trying to shift culture. And patient engagement has historically not been widespread. We had a number of innovators in this space who have gotten early adopters to start to begin this work. It's the early adopters who transition this to the early majority, and they transition it to the late majority, and then it becomes systemic. Moving along that continuum is challenging, but as Eleanor said, you need to get people to follow. We also want to remember that the innovators are not going to get the early adopters to follow. The early majority to follow. It's going to be the following by stage, and so you want to get as many people on board who can help champion this. And it might be interesting to hear from Matt, Pat, and Mary and their experiences with moving this forward within their organizations.
Yeah, and this is Pat. Thanks, Mark. I think those are both great points. Another thing, too, is that has been helpful with us, and I've come from two different organizations with ALS Association and now with Lupus, and I've seen it, different environments, and we're in one area, patient engagement was much more robust and accepted than in the other. And I think one thing that's been helpful to us has been really also pointing to how other disease states and organizations have had success with patient engagement. I think that's been part of helping to get some buy-in, is seeing, while there may be different diseases, different circumstances, and maybe even different goals of the patient engagement, but seeing how it can move the field forward or make other advances has been extremely helpful to show those examples of successes in other organizations and other diseases.
Yeah, and this is Matt as well. Agreed with the previous points that have been shared. And within PQA, the Pharmacy Quality Alliance, we actually have a patient and caregiver advisory panel that has helped to inform a lot of decisions, including the interest in doing a rubric like this, a tool like this. So, and thinking about taking the rubric that was presented today and taking it outside into some of these other organizations. Sometimes it's going to those types of patient panels, communicating the rubric there, or that innovation that needs to happen, and have that collective voice inform a change within the process or within the activity. A lot of our work incorporating the patient community input and actually having patient representatives within our measure development teams has come from those ideas and the innovations within this patient and caregiver advisory panel. So that's been our experience.
One thing that I'll add, this is Elizabeth, is a lot of folks in the patient community talk about kind of the aha moment when people realize that this is a good thing that they should be doing. And one place where I've seen it happen pretty often is when you have a list of the outcomes that patients care about. It's next to a list of outcomes that clinicians care about. And then people can really see how they're different, especially, you know, if they're in terms of some type of a rating or something like that. So sometimes presentations like that can be quite effective in changing people's minds or getting buy-in as well. Mary, sorry if I just cut you off.
Oh, no, thank you for that. And these comments have been really informative. I think, you know, sharing learnings, especially in the drug development process across therapeutic areas. And I think hear from patients and what's important to patients, and when pharmaceutical researchers hear that and understand it, it really is, it can be revolutionary. So I think, you know, exposing that, sharing it, making sure that those outcomes are the outcomes that are meaningful to patients, that what we're studying is what the patients are interested in, and aligning that. And as Mark said, it is an adoption curve and something that's, it's a continuous process. And for the first question that was asked, I would say, you know, even if you're in the middle of a process and you think that you're on that low, insufficient end, there's always learnings there. I think Eleanor spoke to this. And take those learnings for the next engagement that you will have and start very early. We heard that from the FDA, you know, start very early in the process. So those are just some few comments. Thank you.
Thank you. Another question is, earlier it was mentioned that professional staff should be trained in patient engagement. Are there any resources to guide this type of training?
I was just going to say there are some specialized resources that exist. PFMD has done a curriculum that will be made available to a broad array of staff people within industry. You have a group called that is in Europe that has developed a curriculum for patient advocates that can make them experts in a variety of elements of drug development and even beyond, and how to engage them. So there are a variety of different curriculums that are out there and available. The question becomes, how do you tailor it to your specific needs?
I would add that the Patient-Centered Outcomes Research Institute, PORI, also has a lot of resources and tools for this. They're all available on their website. I know that there's an array of different kinds of materials, slide decks, white papers, things like that, that are very useful. I know that's one that we had developed a few years ago. It was geared toward the rare disease advocacy community, so that those patient advocates could be trained on patient-centered outcomes research. Subsequently, that same those materials have been used by other organizations, and they've been adapted to train other patient groups, but they've also been adapted to train a professional association, so that the clinicians were being trained at the same time as the clinicians' patients were being trained. They were being trained together. And so that was also an effective way of seeing that bidirectional information exchange, but also having them both learn it at the same time. I think it was very effective. So those materials are there to be used, but they're also there to be adapted for different circumstances.
This is Elizabeth. One other opportunity that I've heard about in terms of training is there's a number of for professional organizations that have started having short courses for their members in the weekend preceding the main meeting that's geared towards bringing the researchers or the clinicians up to speed on patient centricity and research. As an example, I know that ISPOR, the Patient-Centered Special Interest Group, is exploring developing such a course for the outcomes research community. And I'm also aware that the Health Technology Assessment International Group, their Patient and Citizen Involvement Group also has a workshop preceding the meeting that's intended to educate the community about patient centricity and health technology assessment. One specific question that we received is, has anyone considered having patients a part of a review? So I know that the BMJ has an acknowledgement in papers nowadays that researchers have to submit how patients were involved. If they were not involved, they also have to have a specific statement that patients were not involved. But now that's on the publication side, and so that's more on the research development side. But I'm not aware if they also have patients actually doing peer reviews or serving on the journal review committee.
I'm not aware of any journals that have patients specifically make an effort to have patient representatives on their editorial board or their review panels, but I think it's a great idea. It's certainly something that we can help socialize and get out there in the future, but I don't know of any that are doing it now that have made that publicly aware.
Closest I can think of are the requirements by PCORI on its funded research to engage patients and family caregivers in the distribution aspects. So that might encourage people to be involved in that way, but it's not exactly the same. And I do like the idea. I think it's a good one.
So one other question that we received is quite specific, and I could imagine us having a follow-up as part of our clinical outcome assessment series on this topic. And it was, when considering what to measure, how do you reconcile differences between what the patient thinks are important, for example, that might be fatigue or symptoms, versus what providers might think is important, for example, meeting a target number?
Well, I mean, this is a very common question, and I think you pointed this out earlier, Elizabeth, that you put the two lists together of what clinicians might think are important, what payers might think will be important, and what patients think are important. Those things definitely have differences. I think it's important to consider that you're not going to pick one list over the other and just stick with that one list. You're most likely to end up with some blend because you're always responsive to many stakeholders. But I think that where we are today is that in the past we weren't really asking patients for their list at all, and now we are. We really need to think through and have clinicians and payers and others understand what's important to patients and attempt to collect as much of that as possible and prioritize it, but it doesn't mean that it negates the other things that other stakeholders might think are important. It just means that we have to think through prioritization more carefully and include the patient's thoughts in there because they hadn't been in the past.
So I have just a quick updated kind of crowdsourced response to the question about journal review. So we learned that BMC and RIE have patients included in journal review or are going to be adding patients. And BMJ, JNNP looks like they've also added patients to their editorial board. So two updates regarding that question as well. One other question was, how often will the rubrics be updated? How will you know when the right time to update is?
These are great questions. So, of course, we don't have a now in place for saying, oh, we're going to update 1 year from now. I think we've considered a lot of the documents that we produce as being living documents, and that we know that as there's an evolution in what happens in patient centricity and patient engagement, that these documents will need to be updated. You'll recall that about 3 years ago, we first put out the rubric, the rubric, and we've actually been making plans for updating that this year. Not because a specific event happened, but because we believe a 3-year period is a good time to be looking at it, and that the field has grown and evolved, and I think we'll look at this the same way. As things grow and evolve, we'll take a look at it down the road and see when the time seems right. If you have suggestions on a timeline for that or planning for that, we're all ears. Right now, it's really more of a let's see how the field evolves, see how the documents need to evolve.
Thank you. One additional question is, I noticed that the slides you are presenting allude to a continuum of engagement and also have different descriptors from the rubric published in March 2019, meaningful versus high. Are you planning to revise the published rubric to reflect this more nuanced approach to measurement? So I believe that this was actually one of the updates that we made, and it's reflected already in the rubric that is the final rubric that was published today. This is a change from the 2016 rubric that we had published on value, where it was meaningful versus high. So what we've presented here are exactly from the final rubric that we released today. So I think that we've responded to the questions that we've received at this point. So we wanted to thank everybody for participating. The link to the final rubric went out as part of the invitation for this webinar, but it also will be on the NHC website, of course. I've also included it here. So we want to really just thank everybody for listening, especially thank our speakers and those who contributed to development of the rubric. And we look forward to hearing about how you're using the rubric as well. And we've included a little mini survey on our website right next to where you download the rubric to learn more about how you're using it. If you have any suggestions, anything else, we'd love to hear that feedback as well. Testimonials. And we'll be uploading a recorded version of this webinar to our website as well. So thank you so much. Have a nice afternoon.
Thank you.